contract the muscle, then we stimulate M1, there will be an MEP, and then after that, for a short while, the voluntary contraction will also be inhibited. And this also works if you don't stimulate the contralateral hemisphere, but also if you stimulate the ipsilateral hemisphere. Okay, so then some examples of paired pulse. The first one is short interval intracranial inhibition. And what does this mean? So as I said, we have a conditioning stimulus that is focused on the primary motor cortex. And then 1 to 5 milliseconds later, we have a test stimulus on the same area. And the conditioning stimulus has an intensity that is below threshold, so that is lower than resting motor threshold. And then what it will do is that it inhibits the excitability of the primary motor cortex for the test stimulus 1 to 5 milliseconds later. So that will result, so the test stimulus will result in a smaller MEP if it is preceded by this conditioning stimulus compared to the test stimulus alone. That is what short interval intracortical inhibition stands for. Then we have interhemispheric inhibition, and it actually is similar to SICI, but the conditioning stimulus is now given to the other hemisphere. So we give a conditioning stimulus to this hemisphere, and then after that we give the test stimulus to this hemisphere, and again this results in a smaller MEP. Because the conditioning stimulus also through the corpus callosum inhibits the primary motor cortex. And then last but not least, we have the short latency efferent inhibition and long latency efferent inhibition. And this is actually also similar to the IHI, but instead of giving the conditioning stimulus to the brain, we now give the conditioning stimulus to a peripheral nerve. So that is in the form of electrical stimulation of a peripheral nerve, for example here. And this will also travel to the cortex and there inhibit the excitability of the M1, again resulting, if you then give the test stimulus with TMS, in a smaller MEP. And that can be with a short latency or a long latency, referring to the interval between the test stimulus and the conditioning stimulus. So more on SAI later on. But these are just some examples. This is not an extensive list. You can think of many others. But these are some examples of diagnostic TMS techniques. So let's apply this to Parkinson's disease, which is what we are talking about here, of course. So you can make a table like this, and there has been indeed some research about these different diagnostic TMS techniques applied to Parkinson's disease. And what you can see is that, for example, for resting motor threshold, there is not much change compared to healthy controls, as is for interhemispheric inhibition. However, ipsilateral silent period seems to be decreased, especially in the early phase of the disease. In the untreated patients, later on, it is unchanged. And the SICI was clearly decreased in Parkinson's disease. And for SAI, in the early phases, it's actually unchanged, whereas in the later phases of the disease, where cognitive deterioration starts appearing and also visual hallucinations, for example, SAI starts to decrease as well. More on that later. So these results in themselves, they actually don't tell us that much. Why? Well, it is very unlikely that we will need diagnostic TMS to diagnose Parkinson's disease or to distinguish Parkinson's disease from a healthy state. It's not very likely that we're going to use TMS for that. However, it would be useful if we could use TMS to distinguish PD from very similar Parkinsonian disorders that resemble PD clinically, but actually have a different underlying etiology and also different treatment. So some of the examples are listed here. PSP is progressive supranuclear palsy. MSA is multisystem atrophy. CBD is corticobasal degeneration, and DLB is dementia with Lewy bodies. These are all Parkinsonian disorders that clinically may look like Parkinson's disease, but they have different etiologies. And as you can see, indeed, in some of these different diagnostic TMS techniques, you can see some differences. So for example, CBD, resting motor threshold is increased, whereas in other diseases it is unchanged. In ISP, you can see some changes in the opposite direction for PSP and MSA. The same for IHI, which is unchanged in Parkinson's disease. Unfortunately, SICI is decreased in all diseases that are listed here. For DLB, this has not been investigated. And SII has not been thoroughly investigated for a lot of diseases and has been decreased also in DLB, similar to Parkinson's disease. So this is interesting that there are some differences in the different Parkinsonian disorders. However, I have to note that prospective research has to be done to see if this can actually be used as a diagnostic framework for these Parkinsonian disorders. And ideally, this research would include a post-mortem histopathological confirmation of the diagnosis, because these different diagnoses are often misdiagnosed in clinical practice, which of course will blur the results. So more research is needed, but it is an interesting idea. And for that reason, Cantone et al., they proposed a very interesting diagnostic algorithm for different types of dementias. They focused on different types of dementias. So that's Alzheimer's disease, vascular dementia, CBD again, frontal temporal dementia, DLB, PDD is Parkinson's disease dementia, PSP, and MSA. So they propose first to do to determine the resting motor threshold. And if it is increased, you can end up already in CBD, as we can see here indeed. Apparently in Alzheimer's disease and vascular dementia, these are decreased. And then if it is normal, you will also perform an SII measurement. And if that is decreased, you will end up with either DLB or PDD, and otherwise with these other disorders. So it's not a 100% distinguishment, and you also end up with 3 different disorders without being able to distinguish between those. But still, it is interesting to have this type of diagnostic algorithm, and more research again should be done to see if it is helpful. So that was an overview of using diagnostic TMS to distinguish different Parkinsonian disorders, but you can also use diagnostic TMS to monitor disease progression within Parkinson's disease. And this is where we come to our own research focused on short latency efferent inhibition. And to understand why SAI can function as a monitor disease progression, we have to dive a little bit deeper on the pathological underlying Parkinson's disease and also the working mechanism of SAI. So just really quickly to show you that Parkinson's disease is commonly viewed as a dopaminergic disease. So the dopamine deficiency, dopamine being an important neurotransmitter, of course, the dopamine deficiency in the basal ganglia in the brain, these lead to the classical Parkinsonian motor symptoms that I showed you in the image of this old man in the first slide. However, it is increasingly recognized that Parkinson's disease is actually a multisystem neurodegenerative disorder affecting multiple neurotransmission systems, not only that of dopamine, but also others, including acetylcholine, so the cholinergic denervation. And it has actually been shown that this cholinergic denervation, so acetylcholine being another important neurotransmitter, that this cholinergic denervation is in PD often more severe than it is in Alzheimer's disease. And Alzheimer's disease is usually viewed as a cholinergic disease. So this is an important result that Müller and Bohnen have found out. So focusing a little bit more on acetylcholine, it turns out that a decrease of acetylcholine in Parkinson's disease is involved in a lot of different symptoms that occur in Parkinson's disease, including cognitive deterioration, hallucinations, olfactory malfunction, REM sleep behavioral disorder, postural instability and gait disorders. So even part of the motor symptoms, of course, dopamine play a role in this, but apparently also the decrease of acetylcholine plays an important role in this symptom. And lastly, mood disorders. So that has all been found out by Müller and Bohnen as well. Okay, so a lot of different symptoms that are an important part of Parkinson's disease involve a deficiency in acetylcholine. Liu et al. Have also investigated this. So then a little bit more on SAI, short latency efferent inhibition. Again, you can elicit with the TMS coil on the primary motor cortex with a single pulse. you can elicit a motor evoked potential in the target muscle, which in this case is indeed the first dorsal interosseous muscle. So that looks like this. You give the stimulation to the M1, and then there is a contraction of the muscle. And now in SAI, we add the conditioning stimulus, which is an electrical stimulation of the peripheral nerve, in this case, the median nerve in the wrist. And that precedes the test stimulus of the TMS with 19 to 15 milliseconds. And if you do that, then you will see, so stimulus in the nerve and then TMS, then you will see that you end up with a smaller MEP, smaller in amplitude compared to the TMS stimulus alone. And now what is interesting about this working mechanism is that Di Lazzaro et al. In 2000 already, who have done a lot of research with SAI, they found that if you add a certain drug, a scopolamine in this case, which is a muscarinic receptor blockade, and muscarinic receptors are actually acetylcholine receptors. So if you block these receptors, so acetylcholine is less active, then you will see that the MEP increases again. It is restored in a way, not completely to how it is with TMS alone, but the inhibition is less. So this shows us that the cholinergic system plays an important role in this inhibitory mechanism. So that is interesting. And the theory behind this may be a little bit complicated. I'm just looking how I'm doing on time. I will skip this for now. Maybe if we are running late, I can go back to it if there are questions about it. Anyway, there is a theory why cholinergic system is important for the working mechanism of SAI. But it has also been shown clinically in a lot of different studies where they included Parkinson's disease patients with and without certain symptoms, and then looked at the differences in this short latency afferent inhibition between these two groups. And thus it has been shown that PD patients with mild cognitive impairment has significantly reduced SAI compared to Parkinson's disease patients without mild cognitive impairment. And the same goes for visual hallucinations, REM sleep behavioral disorder, anosmia, and gait disorder. And if you remember, these are actually all these different types of symptoms that were also listed in the list where with the symptoms that are related to a cholinergic deficiency. So this makes sense. If SAI is depending on the cholinergic system, then you would also indeed expect that SAI is reduced in patients that show symptoms that are related to the cholinergic system. So then we come to the research objective of our own research, which is to validate the accuracy of SAI as a reflection of cholinergic innervation in Parkinson's disease by relating SAI directly to PET imaging. So this is the tracer name. I won't say it completely, it will only be confusing. But this is a tracer that binds to the vesicular acetylcholine transporter, which is an important protein in the cholinergic system and creates a nice image of the whole cholinergic system in the brain. So as I showed, SAI has been related to the different symptoms. So it's decreased in patients that show specific symptoms, but it has never been related to cholinergic imaging directly. That's exactly what we try to do, because the benefit of that is if you want to treat patients for a cholinergic deficiency, it would be great if we can actually assess the cholinergic system in a fast and easy way. And SAI can't do that. And that's exactly what we try to show. So the study design is that we include 30 PD patients with normal cognitive functioning, with mild cognitive impairment, and with dementia. So we have a broad spectrum of cognitive functioning. And then we also include 10 healthy controls to compare with the Parkinson's disease patients. So of course we perform SAI, we do the PET scanning, we have a neuropsychological assessment, some other clinical tests, including, for example, sniffing sticks, because also the anosmia was an important symptom. And we also perform some MRI measures. So I cannot show you any results yet. Inclusion is ongoing. Unfortunately, there are some preliminary results that are promising, so that's nice. I hope to have the results ready in a year. But for now, yeah, we are very interested to see what will come out. And then I would like to end with a final note about neuronavigation, which I cannot leave unmentioned, of course, today. Neuronavigation is not so commonly used in diagnostic TMS right now, and we don't use it right now for our own SII measurements. However, I do believe that it can play an important role for diagnostic TMS as well, especially for this specific disease progression methodology, because in that case, if you want to do perform SAI in these different stages of the disease in the same patient, it's actually good if you can target the exact same brain area every time, so that you reduce the variability in that. And of course, neuronavigation is a very, very nice way to do that. So I think using neuronavigation for SAI measurements, especially when you want to do multiple repeated measures, can be of a big advantage. And with that, I would like to end the presentation. I will thank you for your attention, and I'm looking forward to your questions.
Thank you very much, Emil. Very interesting talk, very interesting research. I'm personally already very interested to see what your results will be like. So maybe you can come back in a year and talk more about what you have found. For now, I would like to ask everyone who has a question to type it in the chat, and I will make sure that Emil is able to answer your questions. As of now, we have one question by Jort Fink, and that question is about the decision tree that you showed us. The question is, how clinically feasible do you think the use of this decision tree is?
Yeah, that's a good question. Let me go back to that slide to make everybody clear what we're talking about. Yes, I think it was this one. Yeah, so as I said, it is interesting, and it would be very nice because it would be a very easy way to diagnose, to distinguish different diseases. But before you can actually apply this in clinical practice, this really needs to be thoroughly researched with a prospective study where you indeed post-mortem check for the correct diagnosis. And that's a difficult study, because that would mean that you would have to wait for your participants to die before you and collect their brains to check if indeed you were dealing with vascular dementia instead of Alzheimer's dementia. And actually, these two are not that easily distinguished even then, because they're both occur very often at the same time. So in terms of feasibility, I don't think this will ever be like the only way. Like you go to your general practitioner, he performs TMS, and he will have your diagnosis. I don't think that will ever happen, but it can certainly help in signifying or specifying different diagnoses. Yeah.
All right. I think that is a very clear answer to the question. Jort, thanks you for the answer. Then there is a second question from Satvika Banerjee, and the question is regarding the decision tree. What does the normal motor threshold and SAI mean? Is it based on disease progression?
So normal, that's a good question indeed. Normal means actually, in these type of studies, it means compared to a healthy control group. And this already makes it very troubling, because there are, of course, very big differences between also healthy subjects. And something like a motor threshold can also be dependent on, for example, the thickness of the skull. And that, of course, does not relate especially to different types of diseases. So that's why a prospective study is very important for these types of diagnostic algorithms. Yeah, I hope that answers the question.
I think it does. So thank you very much. With that said, I would once again like to thank you for your interesting talk. And then I would like to continue to the second lecture of the day. Of course, if anyone still has questions for Emil, please feel free to type the message in the chat, and we will make sure that you get the answer to your questions. So then to continue with the second lecture of today by Professor Dr. Teus van Laar, we are really glad that despite the car troubles, he has managed to get to this meeting. Professor Teus van Laar is a clinical neurologist by training with special expertise in movement disorders and especially in Parkinson's disease. And he knows very much about the effect of pharmacological interventions of Parkinson's disease. He works at the University Medical Center in Groningen, the Netherlands, and he has been the medical director of the Parkinson Expertise Center in Groningen since 2016. And today he will be talking about the RTMS treatment of gait disorders and visual hallucinations in Parkinson's disease. So without further ado, I would like to give the word to Professor Teus van Laar.
So good afternoon, everybody. Thanks, Sjors, for the introduction. I see we have a very nice audience of over 40 people. And so I hope it will be as interactive as possible using this communication tool. First question, do you see my slides?
We do see your slides, but it's not set to the presentation view yet. Yes, this is better. Perfect.
Okay, great. Then we do it this way. Okay. The topic of my talk is the role of RTMS, because you are all interested in RTMS. And the topic of this afternoon is, of course, RTMS in Parkinson's. And I will cover two topics, actually. How to use it in people with visual hallucinations and freezing. And I will explain both. Because we switched the following order of the talks, very likely Emil has already told you a little bit about what Parkinson's is, but the general picture that people think it's related to elderly people having some tremor, that's hardly seldom true, because we have patients starting with the age of 20, to be honest, and its major problem is non-motor issues. Because freezing, that's being glued to the floor. If you walk, I will show you a video. And visual hallucinations are, of course, not the primary things you are considering if you talk about Parkinson's. But the major part of Parkinson's is actually the non-motor part. And as you can see, Parkinson's has a long history. So this is the time zero, is the time at which patients mostly are diagnosed. But before that, they have sometimes already 10 or 20 years of all kinds of complaints which never have been connected to Parkinson's, like constipation and a sleeping disorder, what's called REM sleep. That's your dreamy state every person has. And normally we are paralyzed and we only can have our thoughts and dreams. But Parkinson's disease patients are able to act out their dreams, so they are connected to the musculature again. And so they have a loss of smell, and then they start with slowness and stiffness and tremor, and then all kinds of other symptoms are being added to it, as the freezing and the problems with swallowing and the micturition and the constipation, etc., etc. So it's the major burden for patients is the non-motor part, actually. And for two of these symptoms, and perhaps even more, but could RTMS be an option? And this is a slide just to summarize what's Parkinson's about. And actually, it's a very systemic disease. So it's a brain disorder, and it is also a disorder of the peripheral nervous system. And here you see all the complaints people might have, even with vision, and the retina may have a problem as well. So it's a very widespread disease covering actually all parts of the nervous system, and therefore it's a complete total body disease. So very brief introduction about Parkinson's. Now we are talking a bit about visual hallucinations. Everybody knows what hallucinations are, but we have some definitions which is good to have the same ideas about. Actually, we separate illusions and hallucinations. An illusion is if you see something in your environment, for instance, a statue, and you are not completely sure it's the thing you see. It might be a statue, or if it's a little bit dark, you might interpret it as a tree. That's an illusion, and there can be different illusions, externally caused illusions. I will mention a few examples of that, and internal. Hallucinations is completely different. Actually, there's nothing to be seen in the environment, and all of a sudden people see persons, animals, some small objects appearing within their visual field. And that means that they become a bit anxious mostly because they don't expect it, and they are discussing it with their spouses or family members, and they don't see it, and then you have a problem. And so hallucinations are not only visual but also auditory, sensory, and people can have the feeling that there is another person in the room while there is nobody, and that's what we call presence hallucinations. So they have the very strong sense that another person is there. So this is an external illusion. So these are parallel lines, but due to the fact that they are crossed with other lines, you get the impression these lines are not parallel. So that's an external illusion. This is exactly what we all see, and that's due to the fact that the crossing lines are in a different direction. So this is a very well-known and external illusion from Mr. Zollner. So that's an external illusion caused by the way visual information is presented. But there is also an internal illusion, which has nothing to do with the external environment, but this is just what we interpret as a possible view. So the tree, as you can see here with the leaves gone by the wind, have the appearance, or could get the appearance of a face, like we sometimes look at the clouds and then we see all kinds of figures and animals, and if you have a nice summer day, it's a very nice way of spending your time interpreting what shapes are passing by. So that's an internal illusion. We create the image and there is not a real image as such. This is what happens with visual hallucinations. It's your own couch, and all of a sudden there are people sitting on the couch where there is no any object on the couch present. So, but you see them, and you are completely sure there are two persons sitting on the couch, and you start a discussion with your persons if they are available, and if not, people can become very anxious. So it's a very frequently occurring thing. Sorry, I missed the translation, I see. But the cross-sectional data show that about a third of all patients at the same moment have visual hallucinations. And if you follow patients for long term, for instance, 12 years in this case, 3/4 of them will have had visual hallucinations. So it's a very frequently occurring symptom. And as said, very devastating, and mostly the start of a very bad period, because people can't rely on their observations anymore, and that's very bad. We all do every day. We rely on what we see, and if that's not correct, then you have a big problem. Then it's very important to know a little bit to understand what could RTMS do about how do we see. So very practically, what is the way we observe or we look at certain objects? Now it's very clear. A picture enters into the eye, and then it's transmitted by the optic nerve, and then there is here an important switch center, which is called the thalamus, and from there is a complete fiber tract, the optic fiber tract, going to the dorsal, or actually the posterior part of the brain, the occipital cortex, where the primary division is made in what's seen, and that's connected to associated cortices which interpret the picture. So it has a certain color, it may move, it has a certain shape, or if it's connected to the auditory cortex, it can also make a certain noise. So that's the way the signal is interpreted. So we use the parietal lobe, actually, so that there's this part of the brain to look at the information of movement, and to be sure where the object can be placed in the space around us. So the spatial information is connected to the parietal lobe. On the other hand, the temporal, so this is the temporal lobe, the sleepy lobe, the temporal lobe is connected to what can be seen. So that's more the interpretation of colors, shape, etc., but not the spatial information. So spatial information is connected to the parietal lobe, and the context and the environmental context is related to the temporal lobe. So that's the way it's normally done. The problem, however, is to study visual hallucinations, you have a problem, because if you change the environment, mostly the hallucinations disappear. So if you put people in a scanner, then mostly they don't have any hallucinations. So you can't study your topic actually at the same time. And for that reason, we developed a paradigm. We created a model because what is very centrally in the perception of hallucinations is the continuity and the level of attention. So if people have a very good attention, the chance that you will misinterpret your environment is very low. And if your attentional performance is going down, there is a high chance of getting mixed up with what you see. And for that reason, with that background, we created objects and figures and animals coming out of circumstantial noise. And to control for attention, we had color buttons, a yellow and blue one, which you have to push if you saw this color appearing in the picture. And what they had to do is they had to mention the object as soon as possible. And so that means that they had to be very sharp and had to interpret what was the moment that they recognized this picture as a German dog. And I can tell you there were huge differences between people with hallucinations. It took them much longer to do this. And what actually was seen, and here you can see functional MRI pictures, where you see exactly what I just showed you, the temporal and parietal lobe, but this was much less active. This was the control population with Parkinson's without hallucinations, and in Parkinson's patients with hallucinations, there was a clear impairment of this visual processing. So there was a problem in the visual system itself, besides the attentional problem, as I said before. And so the other thing is, of course, not how do we see, because that's the primary visual cortex, but of course, how do we observe? What is our interpretation? And then we are connected to the frontal eye fields, which are scanning our environment all the time and picking up objects with a certain salience, so which means they are different from the environment, and they connect us to our attention. If I only tell nonsense, you all are lost within a few minutes. If I try to create a story, then there is a big chance I get your connection, and we are connected, and I can keep your attention high. So how we observe is, and how we interpret what we see, is related to all different parts of the cortex. So we have to recognize it. And for instance, if we see for the first time an elephant, we have to store that as the picture of an elephant with a certain noise, with a certain movement pattern, etc. The next time we will see the elephant, we will recognize it. So that's the way we observe. We recognize, we couple it to existing knowledge. That's a quite long story to get at my point, because actually we have attentional networks in the brain which keep us alert and give us the opportunity to import information from the outside world. And there are different attentional networks. That's not the topic of my talk, so I will skip that. But that's very important because we know quite precisely which brain structures play a role in keeping this attention at a certain level. And if that's not happening, as you could see in our own model, then there is a much longer time needed to recognize objects, and there is a big chance on misinterpretation. So these are the attention scores we scored in different subgroups, like healthy controls in people with Parkinson's but without hallucinations, and in people with Parkinson's with hallucinations. And as I said, the attentional performance is much worse. The higher the bar, the more bad is the score. So the worst score is seen in those patients with hallucinations. So they have a severe attentional performance problem. And then I come to a neurotransmitter which was already mentioned by Emil as well, acetylcholine. Acetylcholine is the important neurotransmitter which keeps up the attentional performance. It's produced in the nucleus here, the nucleus basalis of Mr. Meinert, and from there is a very myriad network of all kinds of projections going to all the cortical areas where they influence actually the attentional processes. So if you don't have enough acetylcholine, there is a very important basis for getting hallucinations. And if you look at certain drugs, those drugs who may easily cause hallucinations reduce actually the acetylcholine in the brain. And by doing that, you have the gate open for hallucinations because your attentional performance is very that you start hallucinations. The problem with Parkinson's is that there is not only a problem with the production of dopamine, the well-known shortage in Parkinson's, but also in acetylcholine. So you have a very important basis of getting hallucinations because the basic production of acetylcholine is very low. So having said that, we have now the opportunity to measure those cholinergic projections, and what you can see here in blue are those areas who have a very low cholinergic projection from the basal nucleus of Meinert. And as you can see here, the cholinergic system starts deteriorating in the posterior part, being the place of visual impairment and visual perception. So that's of course related. So that's one of the first parts which deteriorate. And if we look at the volume of this nucleus basalis, which I talked, and the risk of hallucinations, it's very clear that the lower the amount of neurons in the basal nucleus, the higher the chance of getting hallucinations. So that's all quite understandable. So there is an attentional performance that's caused by a lack of acetylcholine, and that leads to a misfunction of attentional networks. So that's the dry issue you have to keep in mind. Now we are coming to the RTMS part, but you need some explanation to understand what we're doing. Currently, we only have some medications. Of course, we suplete acetylcholine. We try to increase that by giving particular drugs. And we give antipsychotics, which is an indirect mean because most of these antipsychotics work on the dopaminergic system and not on the cholinergic system. So there is a huge unmet need of treating these patients. And so, as you can see in the list is also RTMS. What is the promise of RTMS? Actually, it's a big promise. What we can do with the current imaging systems is making a connectivity map of the brain, which means actually there are different methods, but I will tell in a minute a little bit more of our own method, that if we create regions of interest of the brain, and we look at how they are interconnected, you get this type of maps, as you can see here. And that's performed by using an imaging strategy called resting state functional MRI, magnetic resonance imaging. And so we can have a kind of activity map of the brain, which regions are interconnected and what are the most important hubs in those connections. And that's analyzed by a method we used, which is called eigenvector analysis. And this eigenvector analysis gives us the opportunity to look at the most important hubs in those connectivity maps. And we can even look at, for instance, the 10% highest connective areas and the hubs which are most important. And here you can see SMA, which is called the supplementary motor area, which is actually a kind of pre-processing area for movements, is one of the most important hubs in the analysis of the particular patient. And what we can do, if we know exactly what are the most important, the most central hubs in the networks we have identified, we are able to modify these hubs by using RTMS. So with brain mapping, we can exactly identify where the spot is, and we can put an RTMS bundle very focused on this particular area. What we did actually in the article which is shown here in brain stimulation. And I will show you the setup. So this is the outcome of the hub analysis. This was the supplementary motor area projected on the particular brain of this patient. And then you see here the bundle of the RTMS beam exactly localized at that place. And we used two stimulation paradigms. First one was a 1 Hz stimulation during 30 minutes, once daily during 5 days, and that was followed by a second tryout, which was a 30 Hz theta burst stimulation, also during 5 days. And the magnificent thing was that for the first time in her life, because this was a lady with Parkinson's with severe hallucinations, and at the same time she had also developed an eye disease, which was actually involving her retina. And so functionally she was actually blind, and she had all kinds of very severe hallucinations which were not reactive to any of the drugs we tried. And for the first time with RTMS, using this analysis and this method, she had 6 months with a significant reduction of hallucinations, because actually we were just treating her most central hub in the network we identified during the MRI scanning procedure. And for the MRI scanning, we are using because that's a very important one, most patients do not hallucinate during the MRI scanning. So we try to get a functional impression of their brain also outside the periods with hallucinations. But for some patients we have had the luck that we could also look at the connectivity maps during hallucinations, and we can compare that. So we know now quite precisely what the way is how to get these data. And what we could see, because it was very important, we made a new MRI after the treatment, and we saw a shift in centrality. So we saw, and it is now a little bit going too far by going into the detail of all these regions, but what we saw is this was the first map, and the second was with this change in centrality. So there were, this is the hippocampus. And the hippocampus, as you might know, is the most important hub in restoring information, and maybe visual information or whatsoever. And so apparently the right and the left hippocampal cortical areas were the ones who showed the most significant change in their centrality, which means there was a complete different circuitry to the visual memory, which is very important, because if I look at my outer environment, the only way to recognize this is that I have a very strong coupling to my visual memory, because it should remember me to things which I have seen previously. So there was a proven shift in centrality after RTMS. So it's not only the story of the patient, but it is real data with a proven shift in centrality.
Professor van Laar, sorry to interrupt. The time is slowly running out, so maybe you could go towards an end of your presentation.
Yes, yes. The end will be very short, just because that was the minor topic. Here you can see a patient with freezing. And you see he's walking a little bit difficultly, but all of a sudden, and you can see he will now turn. He will now turn, and all of a sudden he's blocked and he's glued to the ground, which causes all of a sudden falling death. His walking pattern is all of a sudden blocked and they fall down, and that's the big problem. So that's what we call freezing. And this is the motor circuitry, but I will not go into that detail. But believe me, very important part again is the supplementary motor area. So that's the pre-processing area, here the SMA, supplementary motor area connected to the primary motor cortex, and is actually the pre-processing part before we make a movement. And in freezing, we have very good arguments from a lot of scientific work that if you stimulate this SMA again, that the freezing is diminished. So if you apply local RTMS to this SMA again, then it might have a good effect on freezing. Now that was done not only by us, but by other persons as well, with people who freezed and compared with non-freezers. And there was again a connectivity analysis, as I showed you, for the visual hallucinations. And we did RTMS with a very simple paradigm, 5 seconds per minute, 10 hertz, 20 minutes, so 1,000 pulses, 10 days. And you get the same connectivity maps, but now for freezing. So where are the hubs? And if you treat them, in this case, the patients were treated primarily not on their calculated hubs, but on the SMA, because that had the strongest scientific evidence, then you saw a clear effect on the freezing, and it improved. And that's now a second part we are now performing and using RTMS to treat these patients with freezing. So actually the method is each time the same. We try to define the clinical symptom. We try to understand what is the brain function behind it and actually the dysfunction. And we do that by means of connectivity analysis. And for that you can use different methods, but one of our methods is the eigenvector analysis, where we are able to make these centrality maps. And if we once have found these centrality maps, we can use the particular hubs of these patients to treat them very locally. That's the new route of RTMS in neuroscience, and that's a very promising one, because that's much nicer, this local individualized treatment, instead of putting one pill in the mouth of all the patients with this problem and hoping that it will reach that particular part of the brain which is malfunctioning. And so that's a very promising future, I would say. So thank you.
All right, thank you very much. I fully agree that this is a very promising part. Do you still want to go over these conclusions yourself, or?
Yes, no, I can summarize them, but because time is over. But so yes. The visual hallucinations is part of the spectrum of how we see. And so correcting these attentional networks and focusing on these hubs, that's actually the route for the future for visual hallucinations and for freezing as well. And for freezing, we use a bilateral RTMS, which is not per se the case in the visual hallucinations, because in visual hallucinations you mostly have sufficient effect by unilateral application. Okay, that's where my talk ends.
All right, thank you very much. As of now, I see 2 questions. The first one is by Satwika Banerjee, and he asks what the area of RTMS stimulation is in case of visual hallucination patients.
That's very small. This SMA, that's at the max, it's about a square centimeter or something. square centimeter, perhaps 2 centimeters, but that's so very small areas, which is a big benefit with this hub analysis. These regions of interest are quite small.
All right, I think that answers the question. Then there is a second question by Vivek Misra, who is seeking for your comments on low frequency RTMS of the SMA over the tempoparietal junction in hallucinations, because he mentions that they also have a good effect on low frequency RTMS on freezing.
Yes. Now, the problem is with fMRI research that many of our outcomes seem to be dependent from the paradigm we use. And so there is a big need for harmonizing these models and to see which model predicts actually for what. Because we have just finalized a study in psychotic patients, and there the lateral occipital cortex was a very pivotal common final pathway in the start of hallucinations. So as you could see, actually the start of the visual signal up to the cortex is actually crossing the whole brain. It starts very anteriorly in the retina and it travels throughout the brain, entering the occipital cortex, and from the occipital cortex it spreads through the whole parietal and temporal cortex. So this means that the question is not which part could be helpful, because it's very likely that if you intervene anywhere in this route, you can do something. But the problem is is there an independent final common pathway for all these hallucinations, irrespective the cause? If you are psychotic or have Parkinson's or Charbonnet, or you are born blind, or etc., etc. So there are many reasons to get hallucinations. And the question is, can we determine a kind of final common use without first making a connectivity analysis? Because I can tell you, I can easily talk about it, but it is an enormous amount of work to make a connectivity map of every patient in a particular situation. And that makes the technique at this moment very individualized, but also very unpractical to use in daily practice.
All right, thank you very much. I see two more questions, and with those two questions, I would after those two questions, I would like to continue to the last part of the of this webinar for the sake of time. One of those questions is by Suman Jain, and he asks, first of all, he thanks you for a very interesting presentation, and he asks that depending on symptoms in Parkinson's disease, do we stimulate different areas of the brain? Like for visual hallucinations, the SMA, and for motor symptoms, the primary motor cortex.
Yes, that's what we think. But the strange thing is, the SMA would be related to motor programming, for instance, and of course the primary motor cortex has been tried before. But strange enough, the SMA was the most central hub we found in patients who are hallucinated. And so apparently, if you see people moving, for instance, during your hallucinations, that might release a very active hub in the same area. And so it's not that easy that we could find a similar hub for a particular symptom. But that's, of course, we would think that there is a different network, but perhaps dependent from the role of attention networks, there are some common hubs to be detected.
All right, thank you. And then one final question by Dr. Habil Mali Judith, who is thinking about your very interesting protocol, the 1 Hertz and 30 Hertz RTMS protocol. And the question is, if we transform the cortical activity into inhibition with 1 Hertz, according to homeostatic plasticity, the 30 Hertz stimulation causes inhibition again. What is your opinion on that?
Yeah. To be honest, I think that our thoughts about what is inhibitory and what is activating is a little bit too simple, because it's completely dependent where in the circuitry you are stimulating. And perhaps for the same symptom, you should stimulate at one place and inhibit at another place, dependent from which neuronal circuitries are downstream active. So I'm not sure that we completely understand, actually I'm sure we don't, what is inhibitory and what is stimulative. And we now use the same paradigms, but I think that there is a lack of knowledge there.
All right, thank you very much. I think that is a very clear answer as well. Of course, if there's more questions, I would like to ask the participants to this webinar to ask me these questions over email, and I will make sure that Professor Van Laar received these questions and he can answer them over email as well. So
I have to apologize. I have to leave the meeting because I have another meeting directly after. So it was short, but it was very good to be here. And so,
all right.
Yes.
Thank you very much for your lecture, Professor Van Laar. With that, I would like to continue to the final part of this webinar, which will be a online live demonstration of the MRI guided neural navigator. And this demonstration will be given by Jort Vink, my dear colleague Jort Vink, who also worked with this system in the treatment of stroke patients. So Jort, without further ado, the floor is all yours.
Thank you, Sjors. Can you hear me?
Yes, we can hear you. Thank you.
That's always good. Thank you for the introduction. I would like to give an overview of the RTMS system and the neural navigation system. And I would like to, I'll try to change my talk to include as much of the mentioned protocols or stimulation areas as possible. So I'd like also to thank Emil and Thijs for their interesting talks. A lot of information has been talked about, so I will not be able to include everything in the demonstration, but I'll do my best. A quick overview of the TMS system, and then I'll transition to the neural navigation system. For those of you who are not familiar with TMS, this is what a TMS coil looks like. So in this big box, there is a huge capacitor, which can be charged and which is used to deliver the current through the TMS coil. And for electromagnetic induction, we can induce activity in the cortex. And that's based on the electromagnetic field that is deployed by the current. So what you need is the box, which contains a huge capacitor. When you were working with these kinds of currents, you get a lot of warming, heating. So that's why we have a cooling unit right here. It's a liquid cooling system which actively pumps the liquid through the TMS coil. And in this way, we can manage to perform all kinds of protocols, also high frequency CTBS protocols, without any kind of heating that would be problematic. When you perform peripheral stimulation or more high frequent stimulation, then you would need an additional capacitor. So we also have an additional power supply. So those are the main components of the TMS system. And then we will transition to the neural navigation system. It contains of electronics unit. Electronics unit is attached to the side of the trolley, and it works with a transmitter. So some neural navigation systems use optical tracking, but we use electromagnetic tracking. So a magnetic field is deployed by the transmitter, and it will track different sensors, the position of different sensors in 3D space. So our participant, for example, is wearing a headband. This headband has two sensors in it, and the transmitter tracks the position of these sensors, which means that if I position the TMS coil over the participant's head, it doesn't matter if the participant moves the head. The complete system tracks patient head movement as well as the TMS coil. So those are the most important components. So how do you perform neural navigation? I already loaded the scan into the software. So I would like, for sake of time, to skip a few steps and keep it a little bit short. So what I did previously is already loading the T1 anatomical scan, and then within our software, using the brain segmentation tab, we can generate a brain surface. So this information is directly imported from the anatomical scan, anatomical MRI scan, and visualized in our software. We have different instruction videos on how to perform each of these steps, which can be requested. So specifically for Parkinson's disease, there are different areas of stimulation which you can target. And what Thijs, for example, mentioned is that you can stimulate regions which are connected based on a functional connectivity map. So in this case, the red blob is an fMRI activation map, but this might as well have been a functional connectivity map. So these results that you obtain from your MRI analysis, you can also load into our software and visualize that. I'm going to remove this map for now and focus on predefined targets. So one of the areas that Thijs mentioned is the SMA.
Maybe you can share your screen so people can...
That's a good point. That might make it a little better visible. Can you also see my cursor?
Yes, we can.
I created a target here, the supplementary motor area, which could then be a product of your functional connectivity map in the way that Thijs proposed. But it can also be based on a predefined atlas region. So if we go to the markers tab, we can select popular targets, which are obtained from an atlas and inverse normalized toward the individual patient. I also added different regions like the left hand nod to the primary motor cortex, and then the hand representation, which can be stimulated for motor symptoms. If you're interested in treating motor systems of the lower limbs, then it's possible to stimulate more the leg area. And based on the literature guidelines from last year, there's still good evidence for stimulation of left DLPFC in treating depression symptoms in Parkinson's patients. So all these positions are obtained from an atlas. They're inputted in the software, and then there's one additional step which needs to be performed, which is placement of markers. So we need to make sure that we mark the positions in the MRI scan, which we then also point out on our participant, so that the software can align these two spaces. So in this case, I used a predefined marker set, which automatically placed these marker positions. It's always important to validate these manually to make sure that this algorithm did a good job. So basically, the data is now set up to start navigation. So when I hit auto, it will tell me to capture the Nasion. And to do that, we have another sensor, which is what we call the pointer. I'll stop sharing for now so that you can better see what I'm doing. So on the screen, it will tell me to capture the nasion. So I use the pointer to point at the nasion, and I use a remote control to capture this location. And I do this for all the positions, all the markers in the MRI scan. And now it will tell me on screen that alignment was successful. And I can select the TMS coil, which I want to use for navigation. So to enable visualization of the tool, so you can see that it's positioned over, over the brain. I'll reposition it for stimulation of the SMA. And also on screen, when I'm sharing my screen again, you can see that this gene, which is all about, is pointing over the left SMA. So the yellow beam, which is at the isocenter of my TMS coil, that's the area of interest. So for a figure of 8 coil, this region has the highest intensity for the electrical field that is deployed. And we want to position that over the target. So what we can do is measure the distance to the target. So we can enable that in the settings, and then select a target, left SMA. And now I'll also get an indication on the screen, all right, I'm 2 millimeters away from this target. So if, for example, we start stimulating now, but our patient moves away, we get an auditory warning as well that the stimulation is off. So this is a nice way of navigating to different targets. And I also really liked the suggestion by Emil that if you were doing diagnostic TMS, for example, over the primary motor cortex, you can see based on the MEPs where you are stimulating, whether you're stimulating motor cortex correctly. But if you do repeated measures, you want to be really accurate in your reproducibility. And that's where neuronavigation and storing the stimulation locations comes in very handy. So I'll stick with this for now regarding the neuronavigation. I would like to quickly show a protocol and a GMS protocol which can be used for Parkinson's. I'll also transition to the other screen where you can simply move this. So this is the stimulation software. So I already placed my coil over the SMA, and let's say I want to perform high frequency stimulation. I can open a new treatment and, for example, select Parkinson's disease 10 Hz. I can input the patient characteristics, and it will next ask me what the motor threshold is. And it will perform stimulation at 100% motor threshold. So let's say it's 35. We hit fix MT, go to repetitive mode, and it will now suggest a protocol in which left and right, so with bimanual stimulation, is applied sequentially. And so I'll ask you to place this case, it's for the left hand. So for M1 stimulation, we're now over SMA, so you can pre-configure this protocol based on your needs, of course. And we'll start simulating now. There are lots of protocols in the software. If we go back, there's a huge list of different simulation protocols, which with references to the literature on which they are based, and you can manually adjust those. I think I will limit my talk to this information for now, and if there are any questions, I can always elaborate and show more of the software.
All right, thank you very much, Jort. I think the software is very elaborate with all the protocols for different disorders implemented in it, and additionally with the neural navigation software, it's very easy to target the neuroanatomical structure that you want to be targeting while performing RTMS treatments or RTMS research. At this moment, I don't see any questions regarding the demo, but of course, I would like to ask everyone that if you have a question, please feel free to type a question in the chat, and I would be happy to ask this question to Jort, and Jort will be happy to answer those questions. But if there are no questions, then I would like to ask everyone that if you have a question after this webinar, feel free to send me an email, and we will make sure that the questions are asked to the lecturer of the lectures and of the demonstration. With that, I would like to thank all the speakers of today, Professor Dr. Teus van Laar, Emile Dangermont, and also Jort Vink. Thank you very much for your interesting lectures. Thank you, Jort, for the demonstration of these systems. I've already seen some messages in the chat of people thanking you as well. So yeah, thank you. You did a really good job. And of course, I would also like to thank everyone who attended this webinar. We are really glad that during this pandemic, we are still able to see you guys and explain more about RTMS and neuronavigation through these webinars. And as stated, we will be back with more webinars. We will be organizing these webinars every 4 to 8 weeks. The next webinar will take place somewhere near the end of June, and we will be talking about the application of RTMS in obsessive compulsive disorder. And for this webinar, we will be working together with our friends of Soterix Medical, and we will have Dr. Elahi over, who will have an interesting talk about RTMS protocols in OCD. So keep an eye out on our website, and of course we will send you an email with additional information as soon as we have more information available. As soon as we have processed the recordings of this webinar, we will make sure that you all receive these recordings in your inbox. And with that, if there are no further questions or remarks, I would like to end this webinar. Thank you very much again. And yeah, everybody, please stay safe, stay healthy. And we really hope to be able to invite you all to Utrecht again very soon and meet you all in person. So thank you very much and have a very good day. Goodbye.